Okay, excellent. So good evening, everyone. Welcome. And I am the co-founder and country lead for Women in Global Health Finland chapter. The team at Women in Global Health Finland would like to welcome you to our pre-launch webinar, COVID-19 Decoded. Now, this is actually going to be our first event as a chapter, so we are thrilled that you have all been able to join us during this uncertain time. I just want to firstly say that, this evening we are honoured to host some of the leading female voices in global health security. And I want to take this opportunity to thank our panel in advance for their contribution to this evening. So we have some ground rules before we begin, and we would appreciate it. You are all on mute, and we would like you to keep your microphones on mute, please. If you would like to ask any questions, I would like you to put that in the text box, which is at the side of the screen, which is being monitored by a member of the Women in Global Health Finland team. We will then take those questions and put them to the panel during the question and answer session after the speakers. If you're tweeting as well, we would like you to tag at WGH Finland and use the hashtag COVID5050, as well as the speakers' Twitter handles. Now you will see as we move through the presentation that the speakers' Twitter handles will be displayed on their speaker profile. So also, I think it's really important at this stage to think about, before we begin, our current situation and be thankful to all of the professionals from across the world who are working tirelessly in the response to the COVID-19 pandemic. This includes health professionals, allied health professionals, hospital maintenance and management, to name only but a few. We're ever grateful for their contribution and their sacrifice during this time. And I think before we begin, we need to take a second just to acknowledge how lucky we are to be able to have these people working for us as humans. So without further ado, I would like to hand the stage over now to my friend and fellow chapter co-founder, Sala Atkins, who's going to outline the Women in Global Health Finland agenda for 2020. Sala?
Thank you, Jenny. Thank you all of you for joining us today in our pre-launch workshop. The Women in Global Health Finland chapter has its origins in solidarity to health workers globally. Even in Finland, most of our health workers are female, and though we have a better gender balance in leadership than elsewhere, the balance is not yet where it should be. Our network aims for solidarity and support in balancing decision-making globally through our individual and collective effort within the chapter, in close collaboration with other global chapters and Women in Global Health International. At the same time, locally, we aim to foster early career professionals and support them in their career paths. Our network is intentionally multisectoral and multidisciplinary. We have professionals from the private sector, public sector, and academia. Our members are healthcare personnel, designers, public health professionals, and students. We hope that with our growing network, we support global health expertise here while continuing to collaborate with other countries and settings on an equal basis. Together, we believe that we can redress inequalities present in global health globally. Thank you.
Okay, thank you, Sala. Now I would like to give the floor to our Executive Director and co-founder of the International Women in Global Health Movement, Dr. Rupa Datt. Rupa?
Join video. Let's see if this works. Okay, it looks like I'm not able to join my video, but can you hear me, Jenny?
Yes, and we can see you too.
Oh, you can see. Okay, great. All right. I'm just only seeing the screen. Well, foremost, a very warm welcome to the Women in Global Health Finland chapter. It is really a privilege for me to be able to join and this discussion on both COVID-19, but really women in global health. When we were founded in 2015, we never imagined that we would be able to have such a wide diversity of women and supporters from all around the world that really in the conversation into their local context. So briefly about what inspired the global movement is that we know that there are so many talented women in global health leadership. We look around at top leadership roles underrepresented. And when we really, look at this issue from a deeper perspective of, are we really putting the best minds forward? That when you have diverse teams and when there are represented on teams, better decisions, and especially in the as we are talking about urgency that the world is facing, the pandemic at hand, women in global health seems even as more relevant as we really are talking about how do we really create health systems that are truly equitable, inclusive, and strong and resilient. Women in global health, we call ourselves a global movement, really with the tagline of saying we're here to challenge power and privilege for greater gender equity and health. And that is really rooted in the idea that if we have greater gender equality, we know that it's going to improve the health outcomes for all genders. We also really work on changing the culture in global health. We know that it's not only about numbers and representation, but really the deep-rooted addressing bias and gender norms, and really making sure that women are valued as equally as men are, and also that we acknowledge that gender is a spectrum and it is a fluid social construct. So for us, we really have a deep-rooted philosophy on gender transformative leadership. And that is very much around saying, let's look at the root issues, address those root issues. Let's recognize that becoming gender transformative is a journey. So not something that happens overnight, but it's a progressive learning process. And that we all are really trying to get to this place where, regardless of anyone's gender, everybody is really enabled to reach their maximum leadership potential. Some of the other things that we are doing globally, and it was great to hear the focus on health workforce from the Finnish team, but for us, we are picked up on two policy issues last year that we continue to work very closely on, and one is really related to having gender equity in the global health workforce. We know women make up majority of the health workforce, but when we look at issues such as gender pay gap, the health sector has one of the highest pay gaps at about 26 to 29%. If we look at issues of particularly violence and harassment and decent work conditions, also very relevant to today's conversation. We know that women are facing sometimes upwards of 30 to 50% incidents of bullying, harassment, and sexual harassment. So there's deep issues in our sector that we need to address truly so that all genders really benefit. Women in global health has also been closely working very much on advocating for gender equality in the universal health coverage discussions. We formed an alliance last year that helped contribute to ensuring that gender was a cross-cutting theme, and really ensuring as much as possible that we really had a gender mainstream document. And many of the people on this call and partners and supporters from all around the world have really been key to ensuring that we advance that agenda. And finally, and I would say not least at all, is the very exciting growth of the global movement. We have officially 14 chapters that are part of Women in Global Health, and it is very exciting to say that Finland is at number 14. We have interest from nearly 10 other chapters around the world and are really hoping to continue to grow the global movement. And what's special about our chapters is that they really are an opportunity for people to connect on issues related to advancing women's leadership, issues related to gender equality, but in their local context. We're really trying to do things differently. This is meant to be a flat network that chapters collaborate with each other. The global team is really meant to be an enabler. We really see that you all are shaping what we're advocating and vice versa, where we see an opportunity to really bring your perspective, that we're doing our best to create that platform. And it's particularly exciting for me. Finland really brings this perspective of both health and social well-being. It's also a leader in innovation. And the women that I've met from Finland in the last few years have really been such great advocates for so many issues, but really role model thought leaders that I would say not just only for the community in Finland, but for all around the world. So I really look forward to formally getting to know all of you, work with you, and a warm welcome from the global team. Thank you.
Thank you, Rupa. Thank you for highlighting some of the points in the Women in Global Health movement agenda there, and also how we hope to continue the global movement and support inter-chapter collaboration and knowledge sharing between local contexts. Next, I would like to welcome Ilona Kickbush. Ilona, can you hear me? So Ilona, she's going to provide some insight into why we need a multi-sectoral approach within global health, and also particularly within this COVID response, why we need some global governance structures and how we're going to manage guidance in relation to COVID-19, and also the importance of innovation in this response and how that can support the increasingly constrained resources. Ilona, can you hear me? Okay, so I think that Ilona is going to go further along in the schedule, so apologies for that. I think that next we have Xenia. So Xenia, can you hear me? Have we got Xenia on the line?
Can you hear me?
Yes, perfect. Thank you, Xenia. So Xenia is going to provide a view on gender issues in relation to the health workforce whilst addressing COVID-19. Thank you, Xenia.
Thank you and good afternoon, everybody. It's my pleasure to speak to you about some key gender issues in the global health workforce fighting COVID-19. So let me start in mentioning that the world is addressing the COVID-19 pandemic today with measures that are not so different from what has been done 300 years ago to fight pandemics such as the plague. Quarantine, restrictions of movement, banning of gatherings, and so on. And also the health workforce at that time consisted mostly of women who cared in hospitals as sisters in orders and for family members. However, an important difference compared to the Middle Ages is that at the time those who did not flee from their work were promised significant financial compensations from their authorities, such as in the Kingdom of France. Today, their work is appreciated by clapping hands, and just some token of appreciation has been offered so far to those who are called heroes and considered to be system relevant. The wages of our heroes often range at the lowest level of all civil servant wages, for example, in most African, Asian, and Eastern European countries. And I'm tempted to say, of course, because some 70% of the global health workforce are women, and low wage levels are a feature that we often see in workplaces dominated by women. These low-paid women are now at the front line of the COVID-19 crisis, and they are, for example, doctors, nurses, and pharmacists. They are challenged by an unprecedented burden of work, for which they are paying the highest possible price. It is their own health and even death. WHO estimated some days ago that the global COVID-19 infection rates among health staff amount to at least 10% of staff. In Italy, it is as much as 20%, and the death rate among them is much higher than for the rest of the population. In Italy, it is estimated at 30%, and again, most of them are women. This situation is worsened as recruiting retired health workers aged 65 and more become the rule in most OECD countries, despite the fact that they are part of the high-risk group with highest death rates of all age groups reported. No data is available on the mental health burden experienced by women due to stress, harassment, and ignoring gender aspects in crisis responses. However, it is visible in frequent burnouts and even suicides of nurses reported from countries like China and Italy. This situation derived from deplorable working conditions in times of COVID-19. Largely ignored are fundamental rights of health workers, and not applied are international labor standards, such as the ILO Nursing Personnel Recommendation and Convention, such as WHO guidelines, and sometimes even most basic rules of occupational safety and health, as can be seen in insufficient supply of protective clothing and lacking possibilities of hand hygiene, for example, in the absence of disinfectants in most countries. Also, IPC guidelines cannot be practiced in times when they are most needed. In addition, working times of 18 hours without a break have been reported from countries in the Americas, Asia, and Europe. They are forcing women to decide between work, buying and cooking food, and caring for their families. And working even when sick, when showing mild symptoms of COVID-19, is now also requested from those whose paid sick leave and quarantine regulations were made to protect them, their colleagues, and patients. On top comes stigmatization if concerns are raised at the workplace that could help to reduce the infection rates. Reports from some countries point to the fact that they might be fired or even sent to prison if they tell these stories. As a result of these working conditions, women working at the front line become both victims and vectors of the disease, and this must be stopped immediately. Of course, the current situation is due to the high number of patients, but it is also amplified by a lack of health policy priorities in the past that resulted in many countries in underfunded, inadequate, and unprepared health systems, including in OECD countries. And the situation is aggravated by insufficient implementation of UHC, including preventive measures that aim at reducing pre-existing conditions of older persons. Also omitted was learning from lessons of former pandemics and implementing gender-sensitive workplace policies. And this context has largely contributed to the development of huge workforce shortages, which are globally estimated at 9 million nurses alone. It was not addressed despite the fact that outbreaks of diseases are related to low staffing levels. Among the key reasons for the workforce shortage are indecent working conditions characterized by a lack of support to address needs of women working in the health sector, such as long working hours, low wages, career discrimination, absence of care and family leave, and inefficient retention policies. And all of this is now resulting in important extra workload of women at the front line of fighting COVID-19. To slow down this pandemic, save human lives, and avoid the collapse of complete health systems, we need to implement urgently gender-specific policies to protect women. And they should at least include 5 priorities. First, ensuring the health of health workers by fully implementing rights, standards, and occupational safety and health practices. Second, providing full financial compensation, equal and adequate wages. Third, making psychological assistance and mentoring arrangements available for women in the health sector. 4, creating social dialogue on gender-sensitive policies between employers such as hospitals, health worker unions, women in health representatives, and governments. And 5, stopping work requests from staff that is sick, infected, or from high-risk groups. In addition, immediate action after the crisis should be taken to fill workforce gaps and provide women and family-friendly policies, ranging from flexible work time arrangements to affordable childcare. No question that it will also be necessary to address the broader gender issues beyond the health sector by creating equal opportunities for women, ending discrimination, ensuring representation, and creating respect and dignity for working women. Thank you.
Thank you for those insights into why we need family-friendly policies when considering how to procure and think about the structure of our workforce and the difficulties that women might face that are different to men and the additional responsibilities that they have, Xenia. So thank you very much. Next, I would like to introduce Päivi. Päivi, can you hear me?
Hi, can you hear me? Päivi here.
Hi, Päivi. Thank you. Yes, we can hear you. So Päivi is going to outline the Finnish response to COVID-19, and also she's going to talk a little bit about why women's voices are needed in global health security. Päivi, thank you.
Thank you, and greetings from sunny Helsinki. It's so nice. I'm so happy to hear you all here. I have been working in the global health security field from 2014 when we started to work on the global health security agenda. I was then the chair of GHSA steering group in 2015, and from 2016 on, I have been co-chairing the JEE Alliance, Joint External Evaluation Alliance, which was renamed last year as Alliance for Health Security Cooperation. With my team and partners from all over the world, we have been focusing on facilitating the multi-sectoral capacity building at the country level, both at the developed and developing countries. I have been working many years closely with WHO, which is now leading the global response on COVID-19, and most recently as the vice chair of the executive board. In Finland, we followed the COVID-19 situation closely from the beginning of the year. During the first week of February in WHO EB meeting, I was with my Finnish team at the very core following the situation. We were the second country in Europe with a confirmed coronavirus case in 29th of January. That did not come as a surprise, as Finland is a hub for flight connections for tourism and trade. Despite of the quite small city, high north there, the tracking and restrictions succeeded so well that no further cases came out of that case. Now the hotspot is the Uusimaa region in the southern Finland. Today, we have 1,518 confirmed cases. 160 of patients are in hospital care. 19 patients have lost their lives. We collect gender disaggregated data at national level and can now say that 52% of confirmed cases are male. In Finland, the COVID response is organized in a multi-sectoral cooperation and coordination. This is based on the comprehensive security approach across the whole of society. The model follows our legislation, existing structures and processes, and we have strengthened it further after the joint external evaluation of our health security capacity 2017. A security strategy of society includes pandemic threat, close cross-sectoral cooperation through Security Committee and the Health Security Steering Group is going on, both of which have equal gender representation. We have regular preparedness exercises and low threshold for daily cooperation. The Finnish model for security of supply is based on cooperation between the administration and the business community. Both public sector and businesses contribute to, for example, national stockpiling via the National Emergency Supply Organization. Last week, Finland took into use the medical supplies and protective equipment stored in the state emergency stockpiling, first time after Second World War. These models have been a huge benefit for us. We have been able to scale up our response rapidly and effectively. We are the second fastest aging country in the world, so protecting the elderly is a priority, as well the health care workers and people with underlying conditions. Finland has a long history of preparedness and multi-sectoral action, and of women in decision-making and in the front lines. We were the first country in Europe with full electoral rights in 1906. During the war, 1939, 1940, and 1941-44, women took part in many duties for the defense of the country, as well as took care of families and the industry. I would like to name also our first woman president, Tarja Halonen, and she was elected in 2000. President Halonen has been and is still a strong advocate for global health. Recently, we have become famous of our new coalition government, which consists of 5 parties, all led by women. The Prime Minister Sanna Marin is a 34-year-old woman and also a mother of a toddler. The COVID-19 has made the gendered impacts of outbreak very clear also in Finland. Finland has its challenges in gender equality. The job market is still very segregated, with the women taking most of the health and social care workforce. There is also the uneven distribution of unpaid care. The so-called critical professions for the society to run are also largely occupied by women, such as cleaning personnel and cashiers. They cannot work from home, but have to face the risks of infection every day. We also have a strong tradition of an impact evaluation in policymaking, and we are working to integrate gender perspective into more policy development in an early phase. We have sought to take into account these aspects in the temporary policies. Daycare remains open despite schools and universities are conducted remotely. Schools remain open for grades 1 to 3. There are special measures to protect health and social care workers. Over 70-year-olds are recommended to stay in quarantine-like conditions to protect them from the risk of infection. This also means that grandparents should not take care of children during the epidemic. During challenging times, the probability for risk behavior increases. We are committed to the Istanbul Convention. It is a high priority for the government to prevent domestic and intimate partner violence during the crisis and to ensure sufficient capacity of shelters and the national helpline. They are considered as critical services in the society. These are arrangements for customers of shelters who have to quarantine or isolate. We are also taking measures to protect the social workers of the shelters. To date, the capacity seems to be sufficient, but we are following the situation every day. Apart from violence, we are also preparing for the potential increase in injuries at home. The epidemic and the policy considerations that have to be taken also into account make visible the pillars of the welfare society that we have almost started to take for granted. Daycare, so that both parents can work, schools and free school meals for all children, and of course our healthcare system and universal health coverage, as well as social security system. Gender perspective has to be taken into account as we plan the so-called exit strategy from the current restrictions and all the way to the recovery phase and to strengthening preparedness in a sustainable manner. Basic human rights have to be the cornerstone of our approach. We try to avoid the long-term unemployment, which risks well-being and health, both at the individual and society levels. Having that global view and having worked with different countries and organizations to enhance health security has been tremendously important in my current role in the leadership of the Finnish response. It also makes visible that the SDGs are about at the national level. All goals, all sectors are interlinked, and when we think of how to move forward in the sustainable way, we have to consider all the 17 development goals. I am very motivated to continue the work with my wide global network to help countries recover from this epidemic, but also to be better prepared when we face the outbreak next time. Thank you.
Thank you, Päivi, for those national insights into the COVID-19 response in Finland. It was really great to hear about how the ministry is using a cross-sectoral cooperation with equal gender representation. It was also very interesting to hear about the community infection management in Finland and how the ministry is putting additional support in place to combat increases in potential gender-based violence. I think that we'd like to thank you as well for bringing to the forefront of this conversation why sustainable preparedness in relation to pandemics requires equal cooperation and equal insights into the Sustainable Development Goals, and how that we need to be considering all of them to ensure that we are working towards sustainable preparedness and a sustainable response. So thank you very much for that. We're actually going to go back now to Ilona. Ilona, are you on the line with us now?
Here I am.
Hello, Ilona, welcome. We're so happy.
Hello. Sorry about all this time difference business.
That's okay. I think we all know from working in global health and operating across so many different time zones that we have to be forgiving, especially in the current situation. So thank you for joining us. So just to give everyone a little introduction, Ilona is going to provide some insight into why we need a multi-sectoral approach, as well as referencing some information on why we need global governance structures to manage guidance during the COVID-19 outbreak. And she's also going to give us a little bit of insight into why we need to innovate in this response, because we are facing, across many contexts, increasing resource constraints. And it's probably important to say, and I'm sure Ilona will agree, that every context and every health system does have varying levels of resource limitations, and how we innovate and how we adapt is going to be very important in the response. So Ilona, I will hand that over to you.
Thank you very much. I'm really delighted to be here. Just an additional background. I'm very, very involved now in the global governance response to COVID-19, and I'm a member of the Global Preparedness Monitoring Board that, as you know, gave a report last September warning the world that such a pandemic would be coming. It's not always, pleasant to be Cassandra. We didn't want it to come this soon, but we did say that the world was not well prepared. And I think that's what we are all experiencing. One of the things we're working on now is, and I'll come back to that, is to ensure the follow-up of the G20 virtual meeting that indicated a number of directions that our world should go in now. And why am I talking about these things? I'm talking about these things because I feel this is a point, maybe also like in at the end of the First World War in the 1920s, etc., when the role of women had become very, very visible within a crisis, and to some extent also after the Second World War, that this means women's voice in global politics, in what we call, hard politics, hard diplomacy, etc., has to be very, very present and very visible. We've recognized how vulnerable and how inequitable our world is through COVID-19. and also how vulnerable and inequitable our political and economic systems are. We've very clearly seen that the multilateral system hasn't functioned well, and I'm sure some of the following speakers will refer to the fact that the international health regulations have not been adhered to and are probably also not strong enough in a number of areas. What's interesting to see that in some cases, probably politicians have panicked even more than people. Borders have been erected between countries and between people. And here in Europe, people, basically European politicians, forgot Schengen and said, it's me first. So at first instance, international solidarity, something that I believe has always been a very strong factor of women politicians, was not very important. I think for many people, it's only become tangible now how really interconnected the world is, and how many people at any point in time are not within their nation state. We're faced with a tremendous challenge in terms of refugee camps, in terms of asylum seekers, and even just in terms of tourists. If you think of the fact that Germany has flown home over 200,000 tourists from all over the world. So we're starting to realize that a form of politics in response and preparedness of pandemics that only looks within one's own national space is not sufficient. I think we're also seeing, and this is very worrying, or should be very worrying for women and women politicians, that there are a number of countries like Hungary, like Turkmenistan, and I'm sure more of them, that are using this crisis, the virus, to actually clamp down on their societies, to take away human rights. And the minute a country goes down in that direction, it usually means that women lose their rights, and that women are pushed back into unbearable situations and do not have equal access in society. So we can also see, and the presentation we've just heard, how lucky people are who are actually living in states and in countries with good social insurance systems, with universal health coverage that give consideration for the vulnerable and for human rights. And this is something, the SDGs were mentioned, that we really need to fight for on a global scale. We've witnessed, and that's been very interesting, that some countries for a very short moment have put health considerations over the economy. The German Chancellor, for example, said, we will do what it takes. But what we're experiencing, and again, this impacts on women, women in low wage situations, women in domestic violence situations, women in the healthcare sector, that the attempt to protect health and to protect some of the vulnerable is actually leading to negative health consequences. And they seem to be borne particularly by women. And it is something that we cannot even fully ascertain right now. So it's interesting to look and see what was actually stated in the G20. And I'd just like to highlight three things. The G20 said, we will do whatever it takes to overcome the pandemic. And if you look at their priority list, it starts with protect life and safeguard people's jobs and incomes. That's very, very different from the response in the 2008 financial crises. They say we commit to take all necessary health measures and to seek to ensure adequate financing to contain the pandemic and protect people, especially the most vulnerable. And this is a direction we must surely push, particularly if we see that in some countries we are still experiencing warfare, like in Syria, and the refugee movements based on that. And then they have said, we fully support and commit to further strengthen the WHO's mandate in coordinating the international fight against the pandemic. So I think we need to get it right this time, and I feel that women who are active in global health, in health security, in international health finance, etc., must speak with a very, very loud voice about what it is that we think a new preparedness system should look like, because the next disease X is going to come, and it'll come either from a bat or from a laboratory or in some other way, and we need to be prepared. I think what is a good agenda for women in health security, in preparedness, in global health, and in UHC is to really focus on ensuring global public goods. And I believe in this context, global public goods in a range of areas are important. One, I think we need a mechanism, a coordinating mechanism for the supply and distribution of global public goods, medicines, diagnostics, stockpiling, treatments. And I'm saying here equitable supply and distribution. So this is something that we should fight for. The second key area of global public goods are knowledge and research. And I believe here again, we might look at two dimensions, that women in particular push for research platforms where scientists from all over the world work together. But secondly, also for platforms where we have reliable metrics, data, and information. And I'm sure also that people have already spoken about the way that these data need to be agenda disaggregated, that we better understand the potentials and the dangers of pandemics and how they affect different members of our society. So my challenge to women in health security and in global health is to have a laser-like focus on global public goods, on human rights, and on equity. I feel that women and women leaders need to speak out. If some of you have watched the speeches of some male leaders and some women leaders, think the Prime Minister of New Zealand, think of the Finnish Prime Minister, think of Angela Merkel, and compare it to the speeches by Trump, Boris Johnson, and Emmanuel Macron, you can see a difference on how to deal with a pandemic, and a difference on how to take into account the needs of people and the most vulnerable. This is not about fighting a war. This is about creating an equitable system based on the SDGs around the world. Thank you very much.
Thank you, Ilona, and thank you for highlighting the governance issues relating to the lack of international solidarity during the genesis of this epidemic as it began to move from obviously the epidemic status to the pandemic. I think we also want to thank you for raising the ethical considerations in the context of COVID-19. The issues relating to asylum seekers, migrants, refugees are particularly poignant. We must also acknowledge the governments that are implementing policies that are further restricting women in certain geographies and begin to advocate internationally for better safeguarding of people's jobs, incomes, health and well-being. So next, I would like to present Oti. Oti, do we have you there?
Good evening, Jenny. Can you hear me?
Yes, we can. So this Oti is actually a member of the Women in Global Health Finland board, and we are thrilled to have her speaking with us today. She's going to give us a little bit of insight into the global picture of the COVID-19 response. Thank you, Oti.
Thank you. I thought I would start a little bit from my experience about how health security has become the topic of the day, and it has not been an easy journey. Finland has been supporting IHR, WHO, and preparedness for a very long time, but really everything came to head, and the journey started from the beginning of 2014 when when the Global Health Security Agenda was set up. And I have to say that there were quite a few women leading that process. And I really would like to shout out a few names, starting from the US, Laura Holgate, Beth Cameron, and Bonnie Jenkins. Then from Uganda, Jane Ruth Aseng, Nila Muluk from Indonesia, then Felicity Harvey and Dame Sally from UK, Dagmar Reitenbach from Germany, from WHO, Stella Jungong, and OIE's Susan Corning, and many others were part of that really initial phase and pushing forward a new era in health security. There was quite a lot of pushback in the beginning, and it has become a little bit easier to talk about health security in the context of global health. And I have to say that the situation we are today really shows why that is really important to look at as a cross-sectoral whole of society issue. It has an impact on the fundamental core functions of society, on the economy, on social protection, on equal rights, on security, and the, you know, of course, the public health and the well-being of people. Finland, like Päivi already earlier mentioned, was the chair in 2015, and we had recognized that the IHR and the capacities in countries was not adequate, and there was really no way of measuring how well countries were implementing IHR. There were a lot of countries that reported not having implemented their requirements, and otherwise it was also based on self-reporting. So there was a demand for making some kind of a process where you could evaluate where you are and look at the issues that needed to be strengthened. So there was a development of an external evaluation process. And from 2016, over 100 countries have gone through this external evaluation process. And many of the countries have developed national action plans for health security. And this has been really important now that we are in a situation where WHO needs to assess which countries are most at risk from COVID-19 and what measures need to be taken in those countries, because we already have a data set up from many countries to see where they are and where the gaps in their resources and capacities are, and they have already put in place plans on how to tackle those issues. And therefore, I believe personally very strongly about the need to integrate a long-term solution for building up preparedness capacities in countries through the response and financing of the COVID-19 response. I believe that it was a grave mistake in 2014-15 during the Ebola outbreak in West Africa, where most of the capacities that were put in place for the response in Ebola were not done in a sustainable manner that could have helped the countries there build in a sustainable way their public health functions and their health systems and their health workforce. So I believe that this time around, we need to do it differently. We need to really push forward an ideology where the financing and investment in the response takes also into account preparedness in the long term. Then I would like to highlight to you the resolution that was adopted by the WHO Executive Board in February. this year on strengthening preparedness for health emergencies, implementation of the international health regulations. I was the pen holder of this resolution, and it was the idea came in the autumn last year, and we could not have foreseen how topical of an issue this turned out to be then in January and February. There are a few issues that I would like to highlight that are of particular relevance for women and that have been integrated into this resolution. One is that the continued risk of health emergencies and their multiple and long-term public health consequences and their negative impact on the well-being of people around the world affects particularly vulnerable groups and people in vulnerable situations, including populations in conflict-affected areas and settings prone to natural disasters. And there is a potentially catastrophic human and economic impact of a pandemic on any country and on the world, especially on vulnerable and low-resourced communities that lack access to safe water, sanitation, hygiene services, and resilient health systems. And this is especially true when we see the COVID-19 now spreading throughout Africa. I'm really worried what will happen when this epidemic really takes hold in societies where the basic public health functions do not exist. We will see what happens, but I'm really dreading this spread in Africa and some of the other countries that are low resource countries. Then another issue that is highlighted in this resolution is the attacks on medical personnel and facilities. And this was something that was clearly visible in DRC during the Ebola epidemic. Fortunately, that epidemic seems now to have that we have gained control of that epidemic, and hopefully there is no resurgence of Ebola now in DRC. They are already starting to see an outbreak of COVID there. So it just highlights how the African countries are continuously hit by epidemics, that preparedness capacities in those countries are extremely important, and the sustainability of health services. Another topic that is highlighted here in this resolution is the need for community engagement for early detection, response of outbreaks, and for controlling the amplification and spread of the disease, ensuring trust and social cohesion, and fostering effective responses. And we need to recognize especially the role of women, youth, and people with disabilities and older people in the planning and decision-making related to preparedness, health security, and health services. We need to ensure that their needs are met during health emergencies, especially the access to universal access to healthcare services, to immunization, mental health, psychosocial support, trauma recovery, sexual and reproductive health, and maternal, newborn, and child health. And then we need to address also the issue of a skilled and well-trained, well-resourced health workforce, including community health workers in those countries that have them. So I think that many of the issues that we put into this resolution are extremely relevant in our current response to this epidemic that we have in the world, the COVID-19. and hopefully countries will heed a little bit better the call for building up their capacities in preparedness and taking health as part of the wider picture in the society, as part of the security of the societies, and health gains a new standing in the global arena. I really hope that we see a shift, a fundamental shift in the appreciation for WHO and for other health institutions that are providing extremely important services and advice to us. Like WHO's DG, Dr. Detro says, we need to finance health systems and health security. They are two sides of the same coin, and we need both of them. Thank you. This was my part.
Thank you, Oti, and thank you for highlighting why COVID outbreak will influence will be influenced by fundamentals within our society, and also for stressing that we need to push an ideology where the financing and investment is taken into account how we can prepare for outbreaks such as this in the long term. Thank you again for giving us some insights into why multiple and long-term public health crises can have negative consequences on vulnerable populations, and particularly for people living in conflict-affected areas and for those that are affected by natural disasters. I think we need to acknowledge those that are living in these contexts and contexts that also have ever-constrained health systems where resource shortages are endemic. Thank you as well for highlighting that when we are designing policies around COVID-19 and for future preparedness, we must optimise participation within this policy design, and we must also consider diversity and inclusion. So next we are going to actually have a recording from Sion. Unfortunately, she has been unable to join us today, but she has sent us a voice note. She is going to give us a bit of insight into what it's like to work on the front line of the New York City response to COVID. And she's also been informing advising the Ethiopian government on their preparedness. So I'm just going to try and play the message that she sent us on my WhatsApp. So please bear with me. She has sent us various messages, so you may hear a noise in between it and there may be some background noise. I would also like to say at this stage that if you do have any questions for our panel, that you can enter them or you can tweet them. If you enter them in the text box, there is somebody from Women in Global Health Finland who is monitoring that box. Okay, so I'll pass you over now to Sion.
Good evening, everyone. My name is Dr. Sion Fer. I'm sorry I couldn't be here today. I'm position here in New York City. I'm working in the front lines during this pandemic. I also do work as an advisor to the Ministry of Health of Ethiopia on emergency care and strategic partnership. As most of you guys know now, the US has the highest number of cases, and New York City is the epicenter of this pandemic. And in the past few weeks, we have seen an overwhelming amount of patients and also an overwhelming amount of death, more than we had anticipated and we prepared for. Just to give you a bit of the magnitude, how fast it has progressed here in the past few weeks. A month ago at my hospital, we had one case, and this was a patient that was in the ICU with no travel history, and that was our identified case in New York. Now we have over 45,000 just in the city. And as we speak, we are seeing multiple patients that are coming with shortness of breath, unable to breathe, and most patients are elderly with multiple medical problems. I've described this feeling like being in a war zone. I've had the opportunity to serve in Mosul, Iraq back in 2016, and this whole experience for me has been mind-blowing. I never expected for it to be this bad here in New York City. We thought after the first few cases that it would be contained, but it's been spreading like a wildfire. Unfortunately, most of my colleagues have also been ill with this disease, and at this point, most of our frontliners are also out of commission for the next few weeks. It's unfortunate that the worst is yet to come, because every day it feels like it was worse than the day before. And we are having to make decisions that we didn't have to before. For example, we are getting patients with multiple illness, and the decision of putting them on a ventilator or not. And these are decisions that you have to make with the spur of the moment. And we've started to have those difficult conversations with family members. And usually before COVID-19, we would have these difficult conversations maybe once every week or so with family members. But now every other patient that you see in the emergency department is on the verge of dying. So it's all about how aggressive you want to be with their resuscitation and putting them on a ventilator, and having to explain to family members who need to decide this right there. And the other unfortunate part is that family members are not allowed to visit. So most of these conversations are happening over the phone or through FaceTime. Our emergency departments right now are so chaotic and filled with ill patients of different ages. And of course, the severely ill patients are the ones who are elderly and who have comorbidities. Every time when I walk in the emergency department, what I see are my colleagues in their personal protective equipment, unable to tell who's who behind those big goggles and behind the masks and the gowns. Emergency departments are sometimes chaotic, but now the chaos is to another level. You can't even tell who's who because everybody's wearing big goggles and several layers of mask and a gown. You can't hear each other through this thick mask. So every day is an added challenge of some sort. I never thought I would see this in America, especially when it comes to the scarcity of the resources, ventilators, and personal protective equipment, especially towards the very beginning. But now through various advocacy channels, we're getting more PPEs and more vents, but the difficult conversations continue to happen every day. We haven't seen this amount of dead ever in New York City, as to my experience. And at the same time, you know, the next day is going to be worse. We are hoping to see the peak in the next few weeks. And we know that the next few weeks are going to be extremely challenging. And to make matters worse, it's not only that patients are delayed and come in the emergency department, our ambulance providers are also unable to arrive in a timely manner. Usually, something that would take 15 minutes is taking 3-4 hours because of the increased number of calls. In New York City, our call dispatch centers, for the very first time since September 11 terrorist attack here in New York, they recorded the highest number of calls they've received here in New York. So it has stretched and put a lot of constraint on the health system in general. And the disease has now spread to different nursing homes, prisons, and assisted facility living all over New York City. At the end of my shift, I usually try to walk home and reflect on the day. And also, the other part of me thinks about how this disease might affect when it spreads to Ethiopia and Sub-Saharan Africa in general. I think about all the resources that we have here in the USA and how much constraints it has put on the society and on our healthcare system. And I think about other poor resource countries.
The sound went out.
Yeah, sorry,
now?
just 1 second, apologies.
Those countries might fight this disease. Like I said, it spreads like a wildfire. The numbers start low, and before you know it, it's just growing exponentially in thousands. We've had to we had to change our emergency department, the flow of patients, established a makeshift ICUs in all of our hospitals. And now we're trying to also transfer patients into other hospitals for the non-critically ill so we can free up space. At this point, if you live in New York City and you have symptoms of fever, cough, breath, body aches, you are assumed to have COVID-19. Unfortunately, we do not have the capacity to test everyone. So we're telling people if your symptoms are not worsening or they're not severe enough to make you go to the emergency department, don't come to the hospital. And this applies for everyone. Unfortunately, yesterday we lost an emergency room doctor to COVID-19 who was battling the disease at home, but his symptoms just acutely worsened and he couldn't breathe and he died at home. So that's just a glimpse of what a New York City emergency department looks like and what New York City looks like at this point. They used to be the city that never sleeps. Now, New York is not sleepless anymore. When you walk outside, it's empty. The only thing that you hear are the sirens after sirens. Some of the subways are filled with essential workers. And beyond that, the streets are empty. So it's New York like I've never seen in my life before.
Okay, so that was a very emotional story from Sion. I think that we need to thank her and say how grateful we are for her courage during this difficult time. I believe that I speak for us all in saying that we are honoured that she was able to share her story with us, and we are ever grateful for her sacrifice. I think that we need to acknowledge how difficult it is for health professionals to work under these conditions in terms of how they're going to provide care. How do they stay motivated? How is their mental health going to be affected, not only just during the response, but beyond the response? What implications will that have for their family? How is that different for women that may potentially be also caring for children? And also, you know, to think about their physical health and well-being. I think Suzanne, she raises an important issue on allied health professionals, and particularly in relation to ambulance drivers, she was saying there, and how even their resources are constrained, and how even in New York, the city that never sleeps, so she says so poignantly, has now changed its whole personality as a city. And I think we need to also take a moment to consider how this COVID-19 outbreak is going to affect, as she said, like the social care system and the prison system. And again, just to thank her for her poignant and emotional story. So thank you. Now, next we are going to be moving on to Kaisa. Kaisa, are you there?
Yes, I am here. Can you hear me?
We can hear you, Kaisa. So Kaisa is going to be sharing her thoughts on why global health security needs women at different stages in their career, and why we need to promote a multi-sectoral approach to the COVID-19 response. So Kaisa is actually a friend and a coordinator at Women in Global Health Finland. So thank you, Kaisa.
Thank you, thank you, Jenny. And it's a little bit difficult to speak after the previous speaker. As I understand, for everyone, it is now hard to focus on back to the preparedness and back to the next steps. But I thought I would share just a few thoughts on the importance of having people in different phases of career and having different sectors, and how the Women in Global Health and Women in Global Health Finland can maybe support that. So I work at the Ministry of Social Affairs and Health on global health and on WHO matters, and have been working with Päivi and Outi for the past few years on global health security, and have also had the chance to support in establishing some of these structures in Finland, like the multi-sectoral steering group and also the Alliance for Health Security Cooperation and the global work. So I think it's very important to build capacity to prepare and respond to all hazards, and that means, of course, working across professions but also genders, and across the different levels of experience and phases of career. And of course, during a pandemic, it's not obvious to think about these things, but I think that having different layers in the teams that work on COVID and the current response is key for ensuring continuity and building that institutional knowledge that is needed in the future as well. And unfortunately, as mentioned already, it will not be the last pandemic or epidemic, and we have to learn about this as much as we can, and to think of those ways of building the new preparedness system that Ilona Kikbush mentioned. And the capacity is built through working together, through taking part in the different discussions and themes, and through practical experience. And I've had the privilege of working with wise women leaders who also see this as important. And I think this is definitely something that the Women in Global Health and Women in Global Health Finland chapter want to be facilitating. And then just a challenge that I think it would be good to think about together is also how can we engage different sectors that are necessarily traditionally not so representative with women, or are perhaps structured a bit more masculine, such as defense, trade, finance, infrastructure, and civil protection as well. And these are all very central to health security that is multi-sectoral by nature, and we can see it very clearly in the COVID pandemic. And I think we also, every day we discover new things that new risk areas that have a gender impact, such as waste management, for instance, of the waste that is related to the COVID precautions and the COVID care. So I'm wondering how can women in global health and women working in global health help push the message of inclusive preparedness and response, such as the 5 asks of the Women in Global Health to these other sectors, and maybe at national level and especially in governance, the multi-sectoral structures can support that. And now I'm again thinking about some of our structures in Finland. And we do have strong recommendations and quotas for formal structures in Finland, and that's one way of ensuring equal representation in the bodies. But I think that in terms of really having a gender lens and a gendered approach, it is very important that everyone is working to bring gender into the discussions, even though it wouldn't always be clear or easy. And at the global level, I'm wondering if we can learn something from other movements or other sectors, such as security. And then finally, I think we really need to engage men as well, I hope. And I think there are a lot of men in the webinar, but we need more. And then just to end, I think we are moving to the Q&A, but health security depends on women, and we all depend on health security. Thanks.
Thank you, Kaisa, for sharing your thoughts there. I think that as Kaisa and Oti have both mentioned that, yes, this is not going to be the last epidemic, pandemic or health threat. We need to promote sustainable preparedness, and we need to ensure that women have voices from across the life course in the response planning. Kaisa, thank you for highlighting that we need to engage sectors that might not be traditionally gender sensitive, for example, finance, civic protection or defence, because I know that myself that's not something that I would have considered, and that's why I think it's so important that we hear voices from global health security to bring us into kind of a more multi-sectoral approach to global health in general. Thank you for getting us also to consider how we can push global preparedness in response in these sectors, and how we can support equal representation in these sectors as well. And also for highlighting that we must work to bring gender into the discussion. I know that a few people that I have spoken to have said that they felt like it wasn't something that was needed in the response. And I think that what we have exemplified today is how critical it is to have a gender transformative approach to response. How can we learn from that moving forward? And also, yes, thank you for highlighting that we do have some men in the discussion today, but how can we think about bringing more men into the discussion? How can we make this movement about men and women together working for equality? So thank you, Kaisa. We're now going to be moving to the Q&A. So I'm going to open this up to the panel. If you would just bear with me 1 second, I'm going to unmute you. Okay, so we have a few questions here, and please feel free to continue to add questions to the text box. So this is going to the panel. All of you can have an opportunity to answer this if you wish. So I think that the first one that we'll start with was, can you tell us about any knowledge sharing activities that you're currently doing in terms of COVID learnings for countries with countries, programs or organizations? So I'll just say that again. So in terms of COVID knowledge sharing activities, can you tell us about some examples where you're doing this with countries, programs or organizations?
Jenny, this is Rupa. I can chime in on 2 different places where Women in Global Health is currently engaging. One, we convene a gender equity hub, and as part of that hub, which is co-convened with the World Health Organization, we are sharing resources around the topic of gender equity, health workforce, and emergencies, specifically emphasizing the COVID-19, and that's in close collaboration with WHO, with country examples from the 100+ stakeholders that participate in that. We had a webinar last week, and we'll plan to continue to have a few more series on that. The second thing that we have is that we're part of the COVID-19 Gender and Health working group that was formed. There was a commentary in the Lancet, and there Rosemary Morgan, Julia Smith, and Claire Wenman, who bring both gender and health security backgrounds, had a commentary, and they've created a more of a technical working group to bring the research agenda together. And so we're participating in that and contributing where it makes sense. And then finally, there is an informal community on WhatsApp group, which we're trying to migrate into Facebook, and hopefully we'll have more sharing opportunities. But as far as the resource, we defer. Everybody that comes to us is still the World Health Organization.
Thank you, Rupa. Would anybody else like to add to that question?
This is Päivi from Finland. Hey, I would like to take up that we are privileged in Finland and in Helsinki to have 2 UN organizations that really has an impact on this, and they are UN Innovation Lab until, and then also UN Organization for Planning and Supply, their innovation center is also here. And of course, we have in Finland very high-level research and development collaboration with academy and private sector also. And we are already having collaboration with these UN organizations to then deliver also innovations for third countries.
And this is Outi. I would like to add that the WHO's European Observatory on Health Systems has launched today a health systems response monitor, new tool to analyze COVID-19 response measures across European countries. So this is a really good resource. It only has a few countries now, but they're adding quite a few more as they finalize the text. Thank you.
Great, thank you for that, Päivi and Outi. Okay, the next question we have is from somebody who's coming to us from Korea. And it says, as the situation in Europe is getting worse, especially in Spain and Italy, and Europe is shutting down their borders, I wonder how this decision works in an international politics context, and also wonder how effective is this decision, in your opinion?
Can you repeat that?
Yes, it was a long one. And so the question is, as the situation in Europe is getting progressively worse, especially in Spain and Italy, Europe is shutting down their borders. I wonder how this decision works in an international political context, and also how effective this decision is, in your opinion.
Okay, maybe I can say a word or two here. First of all, yesterday and today we had some reasonably good news. You never know quite how reliable all these graphs and data are, but it seems there is a leveling off of new cases both in Italy and in Spain. So maybe, you know, the absolute worst is over. That doesn't mean that there is not still going to be a lot of cases and particularly a lot of deaths, but this extraordinary growth seems to have ended at this point. We all know how careful we have to be with these data, but there is an indication. That's the first point. The second point was that, yes, as I also said, the European countries, meaning now the countries within the EU, reacted to sort of knee-jerk, let's pull up our borders. And it proved that it has created a lot of difficulties for them. They actually even stopped sharing medical supplies, etc. So the European Commission had to be very, very pushy, very proactive, so that we can see several things now. First of all, that countries have, in quotes, opened their borders again for medical supplies. There's all kinds of initiatives also for taking up patients from other countries. I know that Germany has taken patients both from Italy and from France. Switzerland, where I live, has taken patients from France and from Italy. So, you know, after this short period where, as I said earlier, everyone panicked, a little bit of sense is entering this. They also realized two things, that the more closed the borders are, the less workers that most European countries, mobile workers that they need, you know, living in border areas, are no longer there to work on the farms, actually to work in the caring professions, which is creating a big problem. And of course, various supply chains, which includes food. So there's a lot of discussions around that. So in a way, the European Union is starting to get its act together around cooperating in health. The really, really big issue is, and actually they are better at it than some of the discussion, particularly on social media, has been. And I think you've got to watch that very carefully, because we see there is a clear disinformation campaign around other countries who are now doing what we call mask diplomacy. So, you know, you have China coming in with masks, you have Russia giving presents. So all kinds of geopolitics are going on. And therefore, one's got to be very, very careful around the information, particularly the information that's very negative about the European Union and its response. Last point, where the European Union is facing a tremendous problem, and we don't know how that will be resolved. And I'm sure the Finnish colleagues will also have a word or two to say here, and that is around the financial mechanisms that particularly the Southern European countries have asked for. So there is a range of loan mechanisms that have been opened up in a very, very good way, but countries like Portugal, Spain, Italy, and others are asking for another mechanism, which is now called the Corona bonds, which is basically a joint mechanism where all countries would stand in for each other. And it seems at present, but the Finnish colleagues can correct me if I'm wrong, at present there is no unity yet. And it's turning into a north-south discussion that is very, very difficult and dangerous for the European Union. Over.
Thank you for your comment. Sorry, on you go. If you'd like to further respond, please.
Yes, this is Päivi, and I would only shortly like to take up one proposal that came today from EU Commission to have a EU solidarity instrument worth 100 billion to help workers keep their income and help businesses retain staff. And as I stated in my presentation, it is what we learned from 1990s economical crisis in Finland. We didn't have before that long-term unemployment, but after that we have had long-term unemployment, and that is really a risk for well-being and health. And so it is really important that we concentrate on trying to avoid to get those long-term unemployed people in our societies. Over.
Okay, thank you, Päivi. I think we will have one more question and then we will wrap up. So the question comes from Kushbu, who's part of the Women in Global Health Sweden chapter. And she says to everyone, what is the advice for women working at refugee camps? How have they approached lockdown and how do they prevent intimate partner violence?
This is Oti. Of course, the refugee camps are an extreme setting that is very vulnerable for outbreaks, and it is extremely difficult to contain outbreaks in such environments, and also to have enough facilities for washing your hands and keeping the social distance. So this is really worrying to see how this will go on in the future. The question of partner violence in quarantine situations is something that has already been taken up by multiple governments, Australia and many others, and also here in Finland we are fine-tuned to following up on this situation. It is a risk also for children in those settings where there is not a good family situation. Being at home for the full day, not going to school, is a big risk. So this is something that we will need to look at during this epidemic, and need to take measures to help and prevent those outcomes. Thanks.
Just to add, this is Ilona, that the UNHCR is looking very closely at this, is giving guidelines, etc. And also the International Federation of the Red Cross and the Red Crescent is working very hard, both obviously on the ground, but also in being able to support the people who are working in these camps, and to protect them and the people who are living there. We're seeing that more and more of such camps now have corona outbreaks. And we're also seeing that the refugees who are very, very dependent on news from their mobile phones are being bombarded with false messages. And that is creating a very difficult atmosphere and an additional problem. But UNHCR and IFRC are really working hard on this. Thank you.
Great, and very briefly, I'd like to chime in. There are guidelines from UNFPA to just really ensure that safe spaces are being created in these camps, and we know there'll be further revisions on guidelines, so that's also another resource to look at.
Great, thank you. Okay, so that comes to the end of our questions. We've heard from most of our speakers. I would just like to offer Xenia the opportunity for any final comments. Xenia, do you have anything that you would like to add as we close the conversation?
Yes, thank you very much for giving me this opportunity. Maybe I go back a little bit to the key issues that were the women's issues in the health sector and in the health workforce particularly. I think this is a topic that cannot be dealt with through a pandemic today, right now, but we should also look into the time when the pandemic is finished and what we have to do urgently then. Of course, now we have some real very important things to do right now, like providing supply of protective clothing and things like this. But afterwards, we should think what happened and what kind of rights and human rights and labor rights did we omit during the time. And this includes, as I said before, working time issues. Now they are 18 hours, but also in usual times they are not much less, of course less, but not much. And we have the request to work when sick and when showing mild symptoms now. Usually we should look that everybody has paid sick leave and that regulations are taking into account. And the other thing is that we should really look into gender-sensitive workplace policies to address the issues that are now amplified as well by some contexts that we have not seen before. So I think this is important to take into account when we also want to speak about the coming time after the pandemic. Thank you.
Thank you, Xenia. Okay, so now we're just moving to our final thoughts. So our speakers today have raised some vital issues and some vital and poignant notes that we will be able to contemplate over the coming weeks as this pandemic evolves. So it is evident that we need a multi-sectoral and multidisciplinary approach to address issues relating to provision of care, resource mobilisation, supply chain management, and to enable knowledge sharing between contexts and countries, and to also support the efficient dissemination of up-to-date and correct communication around COVID. We must think about how we can create equitable health systems and global health in the future. And we must also address bias and gender norms and show within global health in particular and global health security and the people that we are providing for that women are valued as much as men. As Rupa Dat had said so poignantly earlier in our discussion, becoming gender transformative is a journey. And we at Women in Global Health Finland want to begin that journey immediately. So on behalf of Women in Global Health Finland team, I would like to thank our esteemed speakers. I would like to thank our audience for tuning in. And I would also like to say a very special thank you to our creative who has helped us create all the beautiful visuals that you've seen today. Elena has given us so much time and has been so good to us and really supported us in our journey towards becoming an established Women in Global Health chapter. So thank you, Elena. I think together with the team, we hope that you will continue the conversation with us at Women in Global Health and at Women in Global Health Finland. Details on our next event will be provided to the participants via a follow-up email, as well as some of the main takeaways from this discussion. I think that I would personally like to thank the Women in Global Health Finland team, because we have really worked very hard to move our launch, which was supposed to be an in-person launch today in Helsinki, to a virtual pre-launch. And we hope to have our launch later in the year. So we hope to see some of you there. So thank you to the team. And I would just like to leave you with one final thought. What does the next pandemic preparedness look like? And how can we ensure that we have women leaders in the room to make sure that the response is as inclusive and sensitive to gender as possible? So with that in mind, everybody, I would like you to take care and stay safe. And thank you for joining our Women in Global Health pre-launch webinar.
Thank you, Jenny, and thank you to everybody else. Really wonderful to be with you all. And again, welcome officially.
Thank you, Rupa and Jenny.
Thank you.
Thank you. It was very interesting. Thank you very much, too.